they are not. But cortisol have some activity as the mineralocorticoid. But as long as your aldosterone production is normal in your body, then you are not going to have the problem, because as soon as your potassium will be high, your aldosterone will be increased and it will put the potassium down to normal. Got idea? Okay, now let's go further. We talked about the tertiary hypoadrenalism, and in this case what we need to see, you tell me, if the patient is having tertiary hypoadrenalism, it means where is the problem? Hypothalamus. And it means the patient is going to have less amount of corticotropic releasing hormone, and due to which there is going to be more ACTH or less ACTH? Less ACTH, and everything else will be same like the secondary hypoadrenalism. So tertiary means the problem is in the hypothalamus, and then due to this there is a problem in the pituitary, and now it will behave like the same as the secondary hypoadrenalism. Means the cortisol is going to be less here, means the ACTH is also going to be less here, means if the ACTH is less, means will there be hyperpigmentation? No hyperpigmentation. No hyperpigmentation, and the sodium may be normal or may be slightly decreased, but the potassium is going to be normal. Got idea? So in this way, in our body, this is going to be the effect of different kind of chronic hypoadrenalism. So all of you tell me, what are the types of hypoadrenalism? Very quickly. What are the types of hypoadrenalism? Acute hypoadrenalism and the chronic hypoadrenalism. Which one is the emergency situation? Acute hypoadrenalism, right? Give me the 5 causes of the acute hypoadrenalism. What is the first one? Waterhouse Friderichsen is caused by this hemorrhage is caused by which septicemia? The Neisseria meningitis, right? Meningococcemia. And then tell me what second cause? Necrotizing adrenalitis caused by which virus? Cytomegalovirus. And it mainly happens in which patient? HIV/AIDS patient, right? And 10% of HIV/AIDS patients, they are found to have this adrenal crisis by this phenomena. And then the third thing I told you, if somebody is taking the steroid for prolonged period and in high dose and they abruptly stop it, then they can get the adrenal crisis. And what is the next one? The severe hypotension. And what is the next one? The abdominal trauma after the accident. And don't forget, if somebody is getting the adrenal crisis, are we going to wait for the confirmation of diagnosis, or are we going to begin the treatment? We are going to begin the treatment, because it is going to be the example of life-threatening situation. And again, in case of the chronic one, we found that there are 3 different examples: the primary, secondary and tertiary. Okay, so I am telling you something and people give me the answer. This patient came to you, his cortisol is down, his sodium is down, and he is having hyperpigmentation. Primary or secondary or tertiary? Primary, because hyperpigmentation is only found in the primary. In the secondary, tertiary, there is less ACTH, less POMC, and that's why there is no hyperpigmentation. Any confusion till now? Okay, so now very quickly we go further. And now our job is to know about when the patient of the hypoadrenalism will present to you, what are going to be the common sign and symptoms. How they present to you, what are going to be the common sign and symptoms. And since I have already taught you the Cushing syndrome, it will be very easy for you to understand the sign and symptom of the hypoadrenalism, because they are going to have just the opposite feature. So in the Cushing syndrome they were fat, now they are going to be lean and thin here, right? So these kind of features will be there. So we try to see what are the clinical features of the hypoadrenalism. And first of all, I must tell you, this patient is going to have more sodium in the body or less sodium in the body. If the patient is having hypotension, there is more sodium in the body or less sodium in the body? Less sodium in the body, right? And due to less sodium in the body, the most common presentation how this patient will come to you is with the weakness, with the fatigueness. This patient will tell you that, doctor, I don't know why, but these days I am feeling very, very weak. I am feeling very, very fatigued. And there are 2 reasons for that. Number 1, the sodium is down, and second number, that the patient of the Addison disease also develop the anemia. Right, they also develop the normocytic, normochromic anemia. So don't forget that they are going to have, the main feature here is going to be the weakness, they are going to have the fatigueness. And the 2 reasons I told you for this thing, number 1, I told you that there is more sodium or less sodium? Less sodium in the body. And the second thing I told you that they are also having anemia. Which kind of anemia? Normocytic, normochromic anemia. Now the second very important feature you should not forget, that this patient will come to you with the weight loss. In the Cushing syndrome we learned that there is more cortisol, right, and there is more fat redistribution, and the patient is going to gain the central obesity. But in this case the patients are going to come to you with what? Weight loss. Clear what I'm saying? Okay, now let's go further. What else can you find in this patient? When this patient will come to you, they may have some hyperpigmentation in the body, but my question to you, this hyperpigmentation will happen in all kind of adrenal insufficiency or only in the primary adrenal insufficiency? On the primary, so Addison disease will have the hyperpigmentation or not? Yes, because Addison disease is the example of primary hypoadrenalism. So hyperpigmentation can happen, and as I told you that this hyperpigmentation can happen in the any part of the body, but the creases of the palm and the vermilion border of the lips are very commonly involved area, right? So this is another very common symptom of the hypoadrenalism. Now let's go further. These patients are also going to present to you with sometime nausea and the vomiting to you. Nausea, vomiting will be another very common presentation of the hypoadrenalism, right? So patient may come to you with the nausea and vomiting. Clear about this thing? And you tell me, this patient, if the cortisol level is less in the body, and you already know what is another name of the cortisol hormone? We also call them the stress hormone, and we also call them the anti-insulin. So if the cortisol is less, it means insulin activity is uncontrolled, and the patient are going to develop the hyperglycemia or hypoglycemia. Hypoglycemia, right? In case of the Cushing syndrome, we saw that people were developing the diabetes, they were developing the hyperglycemia. So this patient may come to you sometime with all kind of features of the hypoglycemia, right? Sometime this patient may also come to you with the bad mood. So mood disturbances will be also found sometime. Depression and the mood disturbances are another very common feature of this disease. So we have seen few common symptoms here. All of you tell me, what is the very common symptom of the hypoadrenalism? The weakness and the fatigueness. Tell me the two causes for this. Decrease in sodium and anemia. Which kind of anemia? Normocytic, normochromic anemia. Tell me the second feature here. Weight loss. Third feature here. The patient is going to have the hyperpigmentation, but not in all, only in the primary. So I must mention it here that it only happens in the primary, not in the all kind of them. And then another feature we learned that this patient may also come to you with nausea and vomiting. What is another feature? All the features of hypoglycemia, for example, sweating and this treming, sometimes becoming unconscious. So this feature may also come. And then patient may also come to you with the mood disturbances. So what do you think? Patient may also come to you with the mood disturbances, personality changes may happen, sometimes even the patient can come to you with the anxiety. So I'm writing here mood disturbances, personality changes, and even with the anxiety. So all these kind of features can the patient present to you with. So mood disturbances, anxiety, and the personality changes. Okay, now let's go further here. One very important thing I must tell you, that whenever a patient is developing, especially the primary hypoadrenalism in the developed countries, which is the most common cause of primary hypoadrenalism? The Addison disease. What is the name of Addison disease? Autoimmune adrenalitis. So remember, when patient comes to you with the Addison disease specifically, not all kind of adrenal insufficiency, but mainly with the adrenal autoimmune adrenalitis, which is 80% common in the developed countries. So what happens? Sometimes this patient may have some other autoimmune disorder together, right? So they are not only going to have the Addison disease, but they may also have some other autoimmune diseases. So this Addison disease, they are going to have the association. They are going to have some associated other autoimmune diseases. Can you give me some example of some autoimmune diseases in our body? Common one. Last time I was teaching you diabetes. Type 1 is autoimmune or type 2 is autoimmune? Type 1 is the autoimmune diabetes, isn't it? So sometimes the patient with the Addison disease, they may also have another disease, the type 1 diabetes mellitus. Tell me some more example of the autoimmune disease in our body. Tell me, give me some names. Myasthenia gravis, yes. Give me some more. Okay. Give me the common ones. Have you heard the name pernicious anemia? Right. Have you heard the name thyroiditis, Hashimoto thyroiditis? Right. So these are the, don't give me the lots of very uncommon names. Have you heard this vitiligo? So vitiligo is also an example of autoimmune disease. So there will be lots of association with the autoimmune disease, pernicious anemia, vitiligo, Hashimoto thyroiditis, the type 1 diabetes mellitus should be in tip of your tongue. In fact, there is one particular name of the disease. We call it autoimmune, right? Autoimmune polyendocrinopathy. Autoimmune polyendocrinopathy means not only one endocrine gland is involved, many other endocrine glands are involved. Syndrome. Right, so we call it autoimmune, give me the full form, autoimmune polyendocrinopathy or polyglandular syndrome. So right now I am not going to explain this thing, but as soon as I will finish Addison disease today, so you people remind me, I will also give you some idea about the autoimmune polyglandular syndrome. So Sava, you remind me, as soon as I finish the Addison, you remind me to discuss something about this one, right? So what is the full form of this one, tell me? Autoimmune polyendocrine or polyglandular syndrome. So lots of other associated autoimmune disease can happen to this patient. So these are the common manifestation of the adrenal insufficiency. Clear about this thing? Now I want people to know that when this patient will come to you, what will be the lab findings that is going to think about this disease? So we can begin from the very beginning. You tell me, the sodium is going to be increased or decreased? Sodium is going to be decreased. If it is Addison disease, if it is the primary hypoadrenalism, what will happen to the potassium? Potassium is going to be increased, right? This patient is also going to have the hypoglycemia or hyperglycemia? Hypoglycemia, so glucose is also going to be decreased. This patient is also going to have the metabolic acidosis, right? So keep in mind, whenever in our body the potassium is increasing, it always go with the same thing. If the potassium is high, then there is acidosis. Generally, not always, but generally, when the potassium is down, then the patient develops the alkalosis. So these patients are also going to develop the metabolic acidosis, and the most common acidosis they develop is going to be the example of normal anion gap, right? So what is the normal anion gap in our body? What is the normal value of anion gap? The 8 to 16. Right, so the patient will have the normal anion gap, and then he is going to develop the metabolic acidosis. Now, one very important thing I am going to add here. Think about this. Last time when I was teaching you the Cushing syndrome, I told you that this patient may have the decentralization or demarginalization of the WBCs. All of you remember this thing? Now, we have found when the patient develops the Addison disease, in the Addison disease, these people, they are going to develop high amount of eosinophil. And this thing has troubled us a lot, that why exactly there is eosinophilia, why the eosinophil in the Addison disease increases. So let me explain something to you. Till now we have got two very believable hypotheses. There are so many hypotheses about that, but none of us we are confirmed about this thing. But there are two very common hypotheses that we believe it. Number one, keep in mind, whenever in our body there is high amount of steroids, in our body whenever we have got high amount of steroids, steroids have one function to push the eosinophil from the circulation to the tissues. Right, steroids in our body, they push the eosinophil from the circulation to the tissues. But in case of the hypoadrenalism, you are going to have the more steroid in your body or less steroid in your body? Less steroid, the cortisol in your body is less, steroids in your body are going to be less. So since steroid is the one to push the eosinophil to the tissue, and now if the steroids are less, then maybe this eosinophil being pushed to the circulation, from the circulation to the tissue is becoming less, and maybe that's why the patient is having high amount of eosinophil in the blood. So this is one hypothesis, that there is decreased amount of what? Steroid. All of you tell me, what is the what does the steroid do for the eosinophil? Steroid pushes the eosinophil from where to where? From circulation to tissues. Right, and if the steroid is less, it means it is not pushing the eosinophil to the tissues, it means the patient is going to have a high amount of eosinophil. So this is one hypothesis. And another hypothesis also, you have to understand this. You tell me, generally in our body, in which situation do we get high eosinophil? When you have got the parasitic infection and when you have got the allergy. Right, so we have found that especially in the Addison disease, we have found that these people, they are also going to develop some allergy to their own substances, and we have given one term to this. What do you call it? Autoallergy. Addison disease patient, they are going to develop the allergy to some of the chemicals to own body, and we have given the name to autoallergy. And then again, maybe this is the reason why the eosinophil is high, but I am repeating, both of these hypotheses can be believed more, but none of these hypotheses we are sure about. Right? So maybe there is decreased steroid, that's why there is more eosinophilia, or there is the autoallergy, that's why the eosinophil is high. So in this way, I gave you some very common lab finding of the Addison disease. Now the question is, when this patient will come to you, how are you going to do the diagnosis? So suppose that this patient came to you with these signs and symptoms, this patient came to you with these lab values, then how are we going to do the diagnosis for this patient? Right? Now keep in mind, if somebody asks you, what is the best initial diagnostic tool? What is the best initial diagnosis tool for the Addison disease? Then your answer should be, we are going to check the cortisol level in the morning 8 a.m. Right? So what is the best initial diagnosis tool? It is going to be morning. Morning means at what time? It's not your morning, right? It's the normal morning. What time? 8 a.m. If it will be your morning, maybe it is already evening, isn't it? So it is the morning 8 a.m. cortisol level. And never forget, generally at this time, generally your cortisol level should be very high at this moment. But if a patient came to you and you found that in the morning 8 a.m. cortisol, his level is less than 100 nanomole per liter, right? Less than 100 nanomole per liter, it means patient is having Addison disease, he is having the adrenal insufficiency. So it's the best initial diagnostic tool, but it is not the confirmatory tool, keep in mind. All of you got idea? So if in the exam the question is coming, which is the best initial diagnostic tool, what is your answer? Morning 8 a.m. cortisol testing, and it should be less than how much? 100 nanomole per liter. Now the question is that what is the best tool, best confirmatory tool? And this one is a little important for you to know. How can we confirm the patient is having the hypoadrenalism? Is by using one test, and this test we have given a name, short, right? We call it short synactin test, syn ACTH, right? Synactin test. First of all, why we are calling it short? Because as soon as we will give this actin ACTH, within 30 minutes we are going to see the response by your adrenal gland, right? Within 30 minutes. We are not going to wait for a longer time. We are going to see for very short period of time, right? So what we are doing in this test is we are giving some synthesized, SYN for synthesized ACTH, synthesized ACTH. So this drug have been given a name. What we call it? Synactin, and this actin is coming from ACTH. Can you see this thing or not? So what is this? We are giving the ACTH to the patient, right? And we are simply waiting for the response, but we are not waiting for very long time. We are waiting for very short period of time. And how short? We wait for how many minutes? 30 minutes. And that's why this test have been given the name. We call it short synactin test. In some books they will not call it short synactin test. They will simply say it is the example of short synthesized, right? Short synthesized ACTH test. Especially if you are going to appear in the UK examination, they will be always using this word, short synactin test. But if you are going to appear in the USMLE, in the USA based examination, then they are never going to call it synactin test. They have different name for it. They call it short syncotropin, syn for synthesized, cotropin test. So many different names for this test, and that's why students are always confused. They are reading in one book, they are giving one name, and they are reading another book, they are giving another name, and the students are confused. All of them are the same thing. What are they? They are the synthesized form of what? ACTH. That's it. So in this test we are giving some synthesized ACTH, and we are waiting for only short period of time. How long time? The 30 minutes, and then we are seeing that what is the response of the cortisol, whether it is increasing or not, and then we are doing the diagnosis. And this is the initial test or confirmatory test? Confirmatory test, right? And what we do in this test is very simple. We give one drug, we call it tetra. All of you write this name down. The drug, this is the synthesized form of the ACTH, right? And this drug have been given a name. We call it tetracosactide. Tetracosactide. So again, in some book they will use the word short tetracosactide test, right? So we will be giving this drug, and generally we use the dose of 250 micrograms, right? We give this ACTH, which is the name is the tetracosactide, and we give in the intramuscular, and we give how much dose? 250 microgram, and we wait for how long time? 30 minutes. And if the cortisol level is increasing, more than 42, right, nanomole per liter, then we say okay, it is normal. But if the increase in cortisol is less than 420 nanomole